Good morning. Let's continue with anti-malarial drugs. In the previous class, we learned about anti-malarial drugs. First, we learned about the life cycle of a malarial parasite. We learned about the chemical classification of the drugs. And we also learned about one more classification where drugs are used based on the stage of the disease. We also learned about chloroquine, which was the mainstay of treatment. Since due to resistance, the use of chloroquine has reduced. We learned about the mechanism action of chloroquine, where chloroquine inhibits conversion of heme to hemaza-N, and chloroquine combines with heme, forming a toxic product which also destroys the plasmodial membranes. Resistance to chloroquine is because of the efflux pump PF-CRT. Relapse is seen due to hypnozoids. Recrudescence is due to resistance. We also understood that chloroquine needs a loading dose due to its high volume of distribution. Also, it is a cumulative drug and it is extensively bound to body tissues. We also learned about adverse effects when used for a short-term duration and also adverse effects when used for prolonged duration. We use chloroquine for several purposes like clinical cure of malaria, extraintestinal amoebiasis, rheumatoid arthritis due to its anti-inflammatory property, for SLE, sarcoidosis, porphyria, lepra reaction, and infectious mononucleosis. Today, let's try to learn about another molecule called quinine. Quinine. It belongs to the family of cinchona alkaloids. It is basically acting on a erythrocytic phase similar to that of chloroquine, but it is less effective and more toxic. What are the actions of quinine? Quinine also has an anti-arrhythmic action. It also releases insulin. So one of the important adverse effects it can cause is hypoglycemia, especially when injected. It can also cause GI tract distress, that is nausea, vomiting, epigastric pain, as it is an alkaloid. In CVS, it causes hypotension. It also has a mild analgesic and antipyretic property. What are the dose-related adverse effects of quinine? It can cause synchronism. Synchronism presents as gastric irritation, chemotrigger zone stimulation, presenting with vomiting, neurotoxicity, hearing and visual defects. It can also cause cardiotoxicity, pulmonary edema and deafness. Rarely, it can result in black water fever. What is black water fever? Black water fever is due to massive hemolysis, hemoglobinemia and hemoglobinuria, which can eventually result in renal damage. It can cause hypoglycemia. We already learned that it releases insulin, which results in hypoglycemia. There can also be associated idiosyncratic reactions along with convulsions on a daily use. What are the uses of Quinine. If we have chloroquine resistant malaria, we can use quinine. Quinine is a short acting drug. We tend to combine it with a long acting drug like doxycycline or clindamycin. It can also be used in complicated severe malaria where we use it through the IV route, intravenous route, cerebral malaria. Other than malaria, it is also used for nocturnal muscle cramps, myotonia congenita and babesiosis. Quinine is infused. Quinine is given as an infusion with 5% dextrose to avoid hypoglycemia and also hypoglycemia induced convulsions. Coming back to the classification, we learnt about two molecules, one chloroquine and quinine. Hydroxychloroquine also has similar properties to that of chloroquine, but it has a more anti-inflammatory property and a lesser adverse effect profile. Now we'll try to learn about one important molecule which is the mainstay of treatment in malaria. That is artemisinin based derivatives like artesunate, arteether, antimethether and arteriolanes. So artemisinin based compounds. These are derived from a Chinese plant named Artemisia annua. Chemically, they have a lactone endoperoxidase structure. These are erythrocytic and zygontocytes. There are several molecules among the artemisinin compounds. These are artesunate, arteether, antimethether, arteriolane, arteether and a prodrug dihydroartemisinin, which is an active metabolite which is frequently used. These act on the erythrocytic phase as well as in the early gametocidal phase. Let's try to understand more about the mechanism of action of our artemisinin based compounds. So, what happens? Artemisinin compound have a endoperoxidase bridge. If we assume this is artemisinin, this is a endoperoxidase bridge. This is broken up by the intraparasitic heme. Intraparasitic heme which is inside the parasite. This releases free radicals which can damage the parasitic proteins, which leads to lipid peroxidation and damage to the endoplasmic reticulum, resulting in lysis or killing of the parasite. Other than this, it also is able to inhibit plasmodial sarcoplasmic endoplasmic calcium ATPase. So what is the mechanism of artemisinin based derivatives? Artemisinins have a endoperoxidase bridge which is cleaved by the intraparasitic heme which is in the parasite, thus releasing free radicals which is going to damage the parasite. These artemisinin based derivatives are potent and they are very fast acting. Hence, these artemisinin based derivatives are combined with other molecules like mefloquine, sulfadoxin, pyrimethamine, and amidoquine, pyronardines, lumefantrines, piperacquine, dihydroartemisinin with piperacquine. So what are these combinations? Why are we combining these combinations? For this, let's try to understand what was the clinical cure for malaria. We had two groups of drugs. One was rapid acting and the other one was slow acting drugs. Rapid acting drugs are chloroquine, quinine, and artemisinin based derivatives. Slow acting drugs are the other drugs like mefloquine, sulfadoxin, amidoquine. These combination of these two are used for clinical cure. Rapid cure is going to help in reducing the parasite count, but the slow acting drugs will help in complete clearance of the parasite. So, artemisinin based derivatives are rapid acting drugs. Let's go back to understand let's go back to understand what are the uses, what are the adverse effects of artemisinin based derivatives. So most of these drugs are water soluble, they have a shorter T-half. Artemether, arteether, these have a shorter T-half. Arteether T-half is 23 hours. Here we understand these are short acting drugs. They are always combined with the long acting anti-malarial drugs. Artemisinins are combined with the long acting drugs. These combinations are called as artemisinin based combination therapy, otherwise called as ACT, which is a very important topic, which is a 5-marker. So please go through it. What are the adverse effects of artemisinin based derivatives? Adverse effects of artemisinin based derivatives are actually few, because this is a recently approved drug 10 to 15 years back. So not much of adverse effects are yet known. We have nausea, vomiting, drug fever, QT prolongation, bone marrow depression, first degree AV block could be there. Can these be used in children and pregnancy? We don't have enough data, but we can use if there is chloroquine resistance. So where do we use artemisinin based therapy? We use it in uncomplicated malaria, where there is chloroquine resistance. Uncomplicated chloroquine resistant malaria by Plasmodium falciparum in the form of ACT. What is ACT? Artemisinin based combination therapy, where a short acting drug like artemisinin is combined with a long acting drug like sulfadoxin or doxycycline, clindamycin, mefloquine or amidoquine. It is also used in multi-drug resistant malaria, in complicated severe falciparum malaria. It is used in cerebral malaria. In Plasmodium vivax, if there is chloroquine resistance and quinine and doxycycline cannot be used, yet again the drug of choice will be artemisinin based combination therapy. What are the advantages of using artemisinin based combination therapy? Artemisinin based combination therapy have faster parasite clearance, safer and better tolerated than IV quinine. Dosing is simpler. We don't need a loading dose like chloroquine. High efficacy and low mortality. Rapid peak we can see with artesunate. Faster clearance and the symptoms are relieved faster. That is why artemisinin is used frequently. So coming back to ACT. ACT is artemisinin based combination therapy. What are the combinations, artesunate based combinations approved by WHO? So artesunate mefloquine, artesunate sulfadoxine with pyrimethamine, artesunate with amidoquine, artesunate with pyronardine, artesunate with lumefantrine. Arteroline with piperacquine, dihydroartemisinin with piperacquine. Let's try to understand a little bit about uncomplicated malaria. There are several combinations of ACT which is available, like artesunate with mefloquine, artemether with lumefantrine, artesunate with sulfadoxine and pyrimethamine, with piperacquine, which are approved, artemisinin with dihydroartemisinin with piperacquine, artesunate with amidoquine, artesunate with pyronardine. This is for uncomplicated malaria. If you are looking at complicated malaria, same drugs are used like artesunate, artemether, artether or quinine can be used. What are the advantages of combining artemisinin based derivatives along with the longer acting? With artemisinin based derivatives along with longer acting drugs, there is rapid clinical cure and also parasitological cure, low recrudescence and absence of parasite resistance with a good tolerability profile. Coming back to our classification, we learnt about these molecules: 1. Quinine, chloroquine, hydroxychloroquine. We also learnt about artemisinin based derivatives. Let's once again go through these drugs. We learnt about artemisinin based derivatives. What is the mechanism of action? It has an endoperoxidase bridge which is activated or cleaved by the parasitic heme, which releases free radicals, which is going to damage the plasmodial membranes. Artemisinin based derivatives are not given alone. They are combined with other long acting drugs like mefloquine, amidoquine, sulfadoxine with pyrimethamine combinations, piperacquine combinations. They are combined and given. Where do we use artemisinin based combination therapy? We can use in chloroquine resistant uncomplicated malaria. We can use it in severe malaria, complicated malaria. ACT. What are the advantages of using a artemisinin based combination therapy? Decreased adverse effects, high clinical cures, good efficacy, high parasitological cures, good tolerability. There are few more molecules which we need to learn. One important molecule among this is primaquine. Before we understand about primaquine, let's try to revise what happens. Let's try to revise with what happens in a malarial parasite life cycle. We know that there is a hypnozoid phase. There is a hypnozoid phase with Plasmodium vivax. We have to lyse this hypnozoid phase. For this, we use drugs like primaquine. So let's try to understand more about primaquine. Let's try to understand about primaquine. Primaquine is a 8 aminoquinolone derivatives. We don't know the mechanism of action. What does it act upon? It acts upon hypnozoids. The sleeping phase of the Plasmodium and the gametocytes. It also acts on all the hepatic stages, whether it's primary or secondary. It acts basically on the pre-erythrocytic forms of malarial parasite. It is having a pro-erythrocytic action. It means it can't act on the plasmodia which is in the RBC, but it is able to act in hepatic stages as well as in pre-erythrocytic forms, and it can also kill the gametocytes. So it acts on hypnozoids and it is a gametocytal drug. If a drug acts on the hypnozoids, it will be used for radical cure. If a drug acts on the gametocytes, it will be called as a gametocidal drug, which can reduce the transmission of malaria. What are the adverse effects of using a drug like primaquine? There can be nausea, vomiting, abdominal pain, uneasiness in the chest, leukopenia could be there, decrease in WBC counts, and there are few important adverse drug reactions like hemolysis, methemoglobinemia, cyanosis, and tachypnea. Why does hemolysis happen? It is more frequently in a patient with G6PD deficiency. Hence, there are a few contraindications for use of primaquine, like G6PD deficiency, those with rheumatoid arthritis, SLE, and those who are acutely ill. It is also relatively rarely used in children. What is the dosing? Of primaquine? Primaquine comes as a 15 milligram base. So we have it as 22.5, 7.5 and 15 milligram tablet. It is also avoided during pregnancy because fetus is G6PD deficiency, which can cause hemolysis. Hence, it's not given in a fetus. Where do we use primaquine? Primaquine is used for radical cure. What happens in radical cure? We have hypnozoids. What are the species which have hypnozoid? Vivax as well as ovale. What is the dosing of primaquine? We are going to be using 15 milligrams once a day dosing for 2 weeks for 14 days. This is for Vivax and ovale. In Plasmodium falciform also we are going to be using primaquine, but this is to kill the gametes so that we can reduce the transmission. In Vivax, for radical cure to kill the gametes, we use it in falciform malaria. So, coming back to our treatment of malaria, a patient comes with suspicion of malaria with a travel history to a malaria endemic area. Patient, we take a smear. We try to analyze whether the patient has uncomplicated or complicated malaria. Once we know the patient has uncomplicated malaria, we try to determine the species, whether it is falciform or vivax. If it is falciform, we try to understand whether it is chloroquine sensitive or it is chloroquine resistant. If it is sensitive, we give chloroquine. If it is resistant, we usually go for artemisinin based derivatives. So, malaria, complicated, uncomplicated. Uncomplicated malaria, if it is falciform, if it is chloroquine sensitive, we go with chloroquine. If it is chloroquine resistant, we go for artemisinin based derivatives. If it is vivax and it is chloroquine sensitive, we give chloroquine. We also know vivax shall have hypnozoids. So, along with chloroquine, we have to give primaquine. If vivax is from a chloroquine resistant area, then we have to use quinine based or artemisinin based derivatives. Artemisinin based derivatives. And primaquine. So, treatment of uncomplicated malaria, if it is falciform, chloroquine sensitive, we give chloroquine. If it is chloroquine resistant, we give artemisinin based therapy. For vivax, if it is chloroquine sensitive, chloroquine. If it is chloroquine resistant, we go for artemisinin based therapy along with primaquine 15 milligrams for 14 days. If it is complicated malaria, we go for artemisinin based therapy or quinine. So, we have understood that we have to treat uncomplicated and complicated malaria. Before we understand this, let's try to understand what are the features of a complicated or a severe malaria. If a patient has any of these features like cardiovascular collapse, jaundice, anemia, renal failure, cerebral malaria, hemoglobinuria, hyperparasitemia, hypoglycemia, impaired consciousness, convulsions, acute respiratory distress syndrome, then the patient is classified. Any of these features if a patient has, he is classified as complicated malaria. So, now we have understood that for complicated malaria, for uncomplicated malaria, we can use artemisinin based therapy or quinine. For complicated malaria, also we can use artemisinin based therapy or quinine. For cerebral malaria, you would use artemether, artemether with quinine or quinine along with supportive treatment. For pregnancy, malaria with pregnancy, chloroquine, quinine, proguanilin with folic acid, pyrimethamine with folic acid is used. Usually we don't use primaquine, tetracyclines, mefloquine. Artemisinin based derivatives, we don't have much of data on them. We also learned we have to give prophylaxis for a person who is visiting a country which is endemic to malaria. So casual prophylaxis is given and as well as suppressive prophylaxis is given. Casual prophylaxis is for inhibiting the erythrocytic pre-erythrocytic phase, whereas suppressive prophylaxis is for suppressing the erythrocytic phase before it happens to prevent the attack of malaria. Here we can use chloroquine, mefloquine and doxycycline. In India we tend to use mefloquine. So what are the drugs which are used for this chemoprophylaxis? You can use chloroquine, mefloquine, doxycycline, proguanilin, atoquinone plus primaquine for 14 days, once a day, 30 milligrams once a day. When does the patient start this? 1 week before and 4 weeks after leaving the area which is endemic where he has visited. We also have an intermittent preventive therapy for patients, pregnant ladies, especially in the endemic areas, which is given in the second and the third trimester. These are the list of few drugs which can cause hemolysis in G6PD deficiency. The most important is primaquine, sulfonamides and dapsone. So we learnt about chloroquine. Its mechanism of action, uses and adverse effects. We also learned about quinine. The other molecule which we learned is artemisinin based derivatives. In this we learned one more thing called as artemisinin based combination therapies, where a rapid acting drug is combined with a slow acting drug and it is given. We learnt about one more molecule, that is primaquine. We also learnt malaria can occur as uncomplicated and complicated. Uncomplicated if it is falciform and it is chloroquine sensitive, the drug of choice is chloroquine. If it is chloroquine resistant, we use artemisinin based therapy or quinine. If it is vivax, again, if it is from chloroquine sensitive area, we give chloroquine. If it is from chloroquine resistant area, we give artemisinin based therapy or quinine. But here we have to add primaquine also. That is 15 milligrams into 14 days. We understood malaria is uncomplicated and complicated malaria. Complicated, what are the features? Patient can have hyperparasitemia, hypotension, hypoglycemia. Unconscious patient can have BIC, acute respiratory distress syndrome. How do we treat this patient who has complicated malaria? Usually we treat with artesunate based therapy or quinine along with supportive treatment. Along with supportive treatment. The rest of the molecules, amidoquine, mefloquine, sulfadoxine with pyrimethamine, all of these molecules are add-ons. Like we have rapid acting drugs and slow acting drugs. These molecules, mefloquine, amidoquine, sulfadoxine, all these are slow acting drugs. Let's try to understand what could be the questions which would come here. 1. Chloroquine could be a main question, a 10 marker. Then we can have 5 markers like chloroquine, artemisinin, compound derivatives, or artemisinin combination therapies. This can also be a 3 marker. Then there could be 3 markers like artemisinin based combination therapy, advantages of this. This is the mainstay of treatment, so we need to learn that. Probably hydroxychloroquine could be a question due to the recent update on COVID-19, which is extensively being used. You can expect a question on hydroxychloroquine. So with this we conclude anti-malarials. Please study. Thank you.